Good evening, everyone, and welcome to tonight's Doctors of BC webinar, ICBC Enhanced Care and Billing Tips in collaboration with ICBC. I'll start us off with housekeeping while folks are transferring over from the waiting room. So this session is in Zoom webinar format. Cameras are off and everyone is muted on entry. Please use the chat for technical difficulties and send all your questions through the Q&A so we do not miss any and can also document them. Comments and upvotes have been enabled in the Q&A, so you can add a comment to an already existing question or upvote a question up top for priority reasons. So we'll be answering them at the end after Stephanie's presentation. You can also raise your hand if you want to ask a live question, and I can unmute you during that time. A survey will also pop up as you exit the webinar and email to your registered email address, which we appreciate your completion and feedback. This session is recorded and the recording will be made available next week in the Business Corner. I'll now pass it on to my colleague Farnaz to speak about the work Doctors of BC has been doing. On to you, Farnaz.
Thank you, Walter, and good evening, everyone. On behalf of Doctors of BC, I would like to warmly welcome you to today's webinar on ICBC billing and the enhanced care model. My name is Farnaz Ferdowsi, and I am Manager of Physician Advocacy at the Doctors of BC. I also support the Doctors of BC ICBC Liaison Committee, which is where this initiative originated. The committee works to identify and to address common challenges that physicians may experience with ICBC and to also identify any opportunities that may be present. And so in collaboration with ICBC, we have developed some informational content to help you clarify processes and to support you in your practice. And we look forward to sharing that with you this evening. We're also very pleased to have our specialist physician representative from the committee joining us here tonight, Dr. Kyla Holtz. Dr. Holtz is a physiatrist, and you will hear from her later this evening as she shares some of her perspectives and her insights as well. Before we begin, just a quick administrative note. You will receive sessional payment for your participation here tonight. Our staff will take care of payment processing, so there's no additional forms or any steps that are required on your part. The only thing we ask is that you do please ensure that your banking information on your Doctors of BC account is up to date in order to avoid any delays with payment. And with that, I will now turn it over to Stephanie to begin our session.
Thanks so much, Farnaz, and thank you everyone for joining us this evening. I look forward to taking you through this 1-hour webinar, helping you with information related to ICBC's enhanced care to support you in your practice when you're treating ICBC customers. I'm just going to take a quick moment for reflection to highlight that we're grateful to listen, learn, and work together on the traditional territories of the Coast Salish peoples. For ICBC at head office, that includes the Musqueam, Squamish, and Tsleil-Waututh First Nations. So I encourage you all to just take a moment to reflect on the lands you're joining us from today and those who walk the lands before us and will continue to care for them after we're gone. We're going to cover a few topics this evening, so we'll start with the basics of enhanced care. We'll move on to the ICBC forms for physicians. We'll spend more time going over the specialized services form, and Dr. Holtz will take us through the form, sharing her insights and experience, and we look forward to that portion of the evening. From there, I'll highlight some key billing information for you both around the reports and then other possibly billable items you may see in your practice. And we will close with some information on ICBC support and resources for you, followed by a Q&A. So I'll try to move quickly through the material so that you can reference this later as you see fit to ensure that we really do capitalize on that opportunity for you to ask questions at the end. So to start with, I think it's important just to take a moment to reflect on the journey ICBC's taken over the past several years. Back in 2019, ICBC existed largely as a compensation model driven by the legal system where there was limited opportunity to perform effective case management and provide a consistent approach to patient care. In 2019, the government introduced changes which started to shift the focus more to care rather than compensation and helped to move our insurance model towards a more sustainable auto insurance system. It was very quickly apparent that those changes didn't really go far enough to achieve the desired results. So in 2021, enhanced care coverage was introduced. So since that time, ICBC is fully committed to a care model that permits us to proactively support our customers, your patients, and strive for the best possible outcomes. This new model supports greater collaboration with health partners, proactive case management, more personal interactions with customers, support for evidence-informed care, and we've got a number of initiatives underway to help address that piece. And there are new tools and resources available to our staff to help support our customers and your patients through their journey of recovery. So moving into some of the basics of enhanced care, I think it's really important to highlight this key principle. So ICBC is required by law to advise and assist every customer with their claim and endeavor to ensure that every person is informed about and receives all the benefits to which they're entitled. So in this system, customers aren't relied on to ask for the different benefits their insurance may provide them, but for us to engage those customers, understand their circumstances and how they've been impacted by their injuries so that we can identify the benefits to which they're entitled and ensure that they're provided to them. Under enhanced care, there are many new benefits that didn't exist before, and I'll take us through 6 of those this evening just to give you a bit of a flavor and understand the different ways that we're showing up for our customers and your patients over the journey of their recovery. So I'll start with the permanent impairment benefit, which is a lump sum payment based on the nature of the injury in the event that someone's permanently impaired or catastrophically injured. It effectively replaces what would have been known as the pain and suffering award in the old tort-based system, and it's available for anatomical, physiological, and cognitive impairments. There are 2 benefits available for caregivers under enhanced care. The first benefit, called the caregiver benefit, is for people whose main occupation is providing care on an unpaid basis, and it's based on the number of dependents a person supports full-time. It's for people who are not eligible for any other indemnity, such as income replacement. There's also a benefit called persons caring for others, which reimburses expenses incurred to people to provide care for a customer's dependents that they can no longer provide as they're recovering from their injuries from a crash. So an example would be a parent who would normally provide caregiving for their young children. They need to hire somebody to do some of that for them as they're recovering, and we can reimburse those expenses. The loss of studies is a new benefit, and it supports minors attending kindergarten through secondary school and students attending post-secondary school. And it's for people who sustain injuries when involved in a crash and when they're not able to begin or continue their studies as a result of the injuries they've sustained. So if there's a gap in their ability to attend school or they just can't continue, this benefit is there for them. The recreational benefit is available to permanently impaired and catastrophically injured customers to cover the extraordinary cost to participate in recreational activities. This is important, obviously, because we want to help reduce isolation and support reintroduction to leisure activities. Examples of funding can include expenses related to adaptive sports, recreational adaptive equipment such as a hand pedal bike, prosthetics for sports, and even attendant care so that they can participate in sports or other activities. The travel and accommodation benefit covers the cost of injured customers to travel for medical appointments, so it can support when someone needs to travel great distances to undergo specialized tests or participate in specialized treatments, but it can also support the travel costs of their everyday appointments. And this can actually be quite easily administered in real time for reimbursement. And finally, we introduced grief counseling. So this is now available to support the family members of a deceased customer when there's a death resulting from a crash. So under the previous system, the impacts to families weren't really accounted for, and we've definitely taken steps to try to address the whole wraparound impact of these severe and catastrophic injuries to persons and their families. Next, I just want to highlight some increases to benefits that have existed for some time, but bringing them up to a value and continuing to change them so that they remain relevant and helpful over time. So the assistance with activities of daily living, which used to be the homemaker expense or attendant care expense, covers essential personal and household activities of daily living that the customer performed before the accident but can no longer do because of their injuries. The death benefit is for spousal survivors of someone who's passed away, and there's an updated limit here. Separate to this benefit, funeral expenses have also increased as a separate benefit to ensure that they're actually quite relevant in a time of need. And finally, income replacement benefits are for full-time, part-time, and temporary earners. And for those that retire, that is a benefit that has increased. An interesting note here, just for interest, is that we have a separate top-up insurance product called Income Top-Up, and that supports people who would be in a high earner category. So where basic insurance may not cover their income loss sufficiently, there's a top-up product, and it's also available for purchase for people who are normally pedestrians or cyclists, and that just allows people to have the right level of insurance for the activities that they enjoy. Moving on through this section, trying to keep it a bit quick, but still give you the information. I want to highlight some changes and really just share that enhanced care is an evolving insurance product. It's not static like the old system, and ICBC is taking great care to try to identify areas where we can continue to shift and evolve to really meet the objectives and intentions of enhanced care. So the first area is related to medical equipment. So ICBC is now primary payer for medical equipment under the medical equipment benefit. And this is really, really important because it eliminates the delays created when we have to engage with another insurer who before these changes would have had to be the primary payer on the benefit before we step in. So this helps get the equipment where it needs to go when it's needed without the delays of liaising with another insurer. There is an exception to this change in that a customer who has coverage through WorkSafe BC or a federal government agency like the RCMP or Canada Post, that benefit plan would go first before ICBC. But in all the other cases, we're able to implement the medical equipment benefit right away without delay. And then lastly, I just want to point out family counseling. So this has been recently introduced, and it provides support and counseling services for family members of a customer whose crash-related injuries are life-altering. So it helps support the family and the individual with the significant emotional impact that crash and those injuries have had and may continue to have. So listed here are many, but certainly not all of the benefits a customer or your patient may be entitled to. And you can find a quick guide to enhanced accident benefits on the ICBC physician page if you're interested in revisiting this or learning a little bit more. The next area of enhanced care I want to draw your attention to is pre-approved treatment. So these are treatments that your patients would have had access to in the first 12 weeks following their crash. So I understand as specialists, you may not see our customers during this time frame, but it's important to know that there are these benefits available so that a customer can access the treatment they think they need right away without delay and without a need for a physician referral. This also supports customers who have a preferred provider or a preferred way of caring for injuries and helps get the ball rolling without delay. So ICBC funds these treatments, like I said, without a referral from a physician or nurse practitioner, and patients have access to the healthcare provider locator on ICBC.com if they need help finding a provider in their area, or in the case of counseling or psychology services, a virtual provider that they can connect with. When a customer will require additional care beyond that 12-week early access period, or there's indication that the customer's recovery is not progressing as expected, the treating practitioner is responsible for submitting a treatment plan or a funding approval plan for ICBC to make a funding decision. So this helps reduce the burden on the primary care provider for extending physiotherapy sessions, for example. Occupational therapy isn't noted here, but it is absolutely something that we can support in the first 12 weeks after a crash. Customers who require occupational therapy support within the early access period are often identified because of a hospital stay or a need for return to work planning. And again, that's where ICBC can step in and identify that that's a benefit a customer would need and help support putting that in place. So we can help connect the customer with an occupational therapist in their community to support their specific needs. Your patients are encouraged to speak with their ICBC recovery specialist for support if they need help finding an occupational therapist or a specialized treatment provider. We definitely want to support our customers in accessing the care they need when they need it. And we understand that customers may not always know how to put those pieces together. So I want to bring your attention just to a general claims process. So obviously it starts with the customer reporting the crash and their injuries to ICBC. We do know sometimes they may report a crash and realize later that they're experiencing injuries. It's important for them to follow up with ICBC and add those injuries to the claim. From there, they would have an injury claim with us and be able to attend early access treatment. If they attend a family physician or nurse practitioner, they may complete a report to share with ICBC to help us understand what the injuries are, what the recovery journey may look like, and what interventions may be recommended at that time. If recovery is prolonged and additional support is needed, there are a few different ways that a customer or a patient may be supported. So they may be referred for a specialist consult to yourselves, and there is the specialized services report that can complement that and help provide information to ICBC after that consult. We also have a comprehensive medical assessment avenue. So in complex recoveries, we can support the customer in accessing a specialized medical assessment to help identify barriers and overcome those, creating a plan that the healthcare team can enact or at least be informed by. And a really important note is that ICBC continues to fund benefits and supports for as long as necessary, even a lifetime. And I know that there have been questions about whether changes in health status may come up later and whether benefits can be reintroduced at a later time. And that's absolutely part of this system. So even though a claim may go essentially closed for a period of time, if something does change, we can revisit that and we can start providing benefits again at a later time. Some examples of additional support for long or complex recovery journeys are listed here. So I've already highlighted occupational therapy, but we can fund speech language pathology or audiology as well, medical equipment, medication, and supplies. We have a customer support desk, which is a really helpful place for customers who need help just doing the administrative processes of their claim. If they need help getting through some of the paperwork or taking some of the necessary steps to move some of the benefits forward, a customer support representative can support them there. Like I mentioned earlier, we have personal care assistance, and there's many other programs and benefits that try to provide that full service and support for a customer when they need it. So what does this mean for patients? Patients have access to treatment that facilitates their recovery or addresses a decline in physical or mental function because of their injury. Collaboration with physicians, nurse practitioners, and allied health professionals support ICBC in identifying and funding necessary treatment over their entire recovery journey. And like I said, even for a lifetime. For some people, their interactions with ICBC may be quite short-lived, and for others, it can be a very long relationship with us. Under enhanced care, claims are handled by what we call ICBC recovery specialists, or formerly adjusters, and this just reflects their role in supporting the recovery journey for the patient, and not just the adjudication of the claim. So when you hear recovery specialist, really this just means the ICBC file handler or adjuster, as you've probably thought of these people in the past. So I'd like to move us into the section on ICBC forms and take you through generally what are the forms physicians may see, and then go into more detail about the specialized services report you may see in your practice. So physician reports support patient recovery in a number of ways, helping us identify early what the injury diagnosis and recovery goals are. Again, helps us identify and implement different benefit entitlements or specialty support programs as applicable. It helps assist with timely access to recommended treatments. So if there are questions about whether a treatment is medically necessary and it's been identified in a report, it is very easy for us to move forward on that. It helps inform ICBC funding of treatment beyond the early access period, so especially where a patient's not recovering as expected and we may not be sure whether a treatment is working or may be recommended at a different point in time. Reports can be sent proactively with patient consent, and the Doctors of BC have published the ICBC Consent to Sharing Information form to support the collection of patient consent if you would like that resource or tool to be incorporated into your process. So reports are designed to support the level of information required. So family physicians may complete one of 3 reports when they see a customer. And I say may because they're not going to complete a report every time they see an ICBC patient. The standard report and extended report are to support an initial assessment. So the extended report being for more extensive or involved injuries with longer recoveries or more recommendations associated with them. And the reassessment report supports that patient when their recovery is not going as expected and an updated diagnosis or treatment plans required. We may also request a reassessment report at some point down the line just to help get more information if there's been a bit of a lull and we're really not sure what that patient or customer may need at that point in time. The specialized services report can accompany a specialist consult to provide ICBC with timely information that's not normally included in a typical consultation letter completed by the physician. So it's intended to complement what would normally be captured in that consult visit, but really help ICBC again inform any funding requests or implement any recommended treatments as a result of that specialist consult. So what is the purpose of the specialized services report in full? As I mentioned, specialized services report are for physicians completing a consult, whether from a family physician or a nurse practitioner, and it's for injuries related to a crash. The fee of $275 compensates for a complete report, and the consultation itself is billed using MSP billing codes. The specialists and family physicians with a focus on sports medicine or another practice focus can complete the report for ICBC related consults as well. The report allows for additional information sharing with compensation for time involved and can hopefully be easily incorporated into your practice flow. And I look forward to hearing how Dr. Holtz has done that this evening. And then the report provides ICBC with early information to support patient recovery goals, as I mentioned, and all those different benefit entitlements. So when do you fill it out? Following an initial consultation or perhaps a follow-up appointment. So I know there are cases when you see a patient and you need more information. You need imaging or special tests or more information to actually convey anything meaningful. It would be totally reasonable to complete the report during that follow-up appointment. And I think with a bit of experience, that would probably feel really easy to identify those cases. When a report has been requested by ICBC, so if we don't receive a report from that consult, we find out that you've seen our customer that patient, and we think that there could be valuable information there for us, we may reach out and request it. And then if a patient's been re-referred, you can complete that report again and give us that new information. So it's recommended to share the report with ICBC in a very timely manner because we want to action anything you've shared with us in a timely way. So 4 to 6 weeks is kind of on the latter side. That would be really supportive for that patient and is a general guideline. Physician reports are available on the ICBC Health Services physician page and in the forms repository in Pathways. Again, just touching on patient consent. So when providing a report proactively to ICBC, it's important that you collect patient consent, and you can do that by explaining that as part of a referral for ICBC injuries, it's helpful to share information with ICBC. Again, patients have the ability to say no thank you, and that's totally fine. As I mentioned, there is a resource to support this for you. And if a patient doesn't provide consent, you could choose to complete the report and let ICBC know that you have it, should we request it. And then we can send that official request letter to you. And it would very clearly cite the section of the legislation and regulation that entitles us to request it without patient consent, and that would cite section 28 and 28.1 of the Insurance Vehicle Act. So those request letters will very explicitly cite that and make it very clear under what authority we have. So I am going to pass the speaking off to Dr. Holtz and just support the conversation from there.
Thanks, Stephanie, and thanks for having me on this panel. I really enjoy my work on this committee, and I'm excited to be able to share my knowledge to help you get advocate for your patients to get the treatment they need and the support they need, as well as share how you can be compensated fairly for the work you do. So we're going to walk through the Physician Specialized Services report, which you can see in front of you. This is preloaded into my electronic medical record form section. And so we've configured the settings such that the clinic name and address, as well as the patient information and some of the physician information pre-populates. If you are running your own practice, then you know that often it's challenging with referrals to get claim numbers and date of crash. And so I would encourage you to train your staff to be on the lookout for accident-related injuries and to collect that information proactively. So once you have that section of the form filled out, then you can scroll down, and I'll just have you advance the slide where we come to the diagnosis section. My interpretation is that the primary diagnosis is really from the lens, your specialty. So if someone's referred to me, it's likely because of a strain injury to their neck. And some of the secondary diagnoses may be concussion in the context of a whiplash injury, a mood disorder, or a vestibular disorder, kind of secondary injuries unrelated to the primary complaint for which the patient has been referred. The nature of the injury and the body part are the most important sections here. Don't get in the weeds with the ICD-9 codes. ICBC has kindly offered to complete that work on the back end if they need it for tracking. And I do find that the additional comment section is really helpful to provide some context. For example, I often fill this form out in my inpatient work when someone comes with polytrauma. And so the nature of the injury is polytrauma, and I try and list out kind of, several fractures, a head injury and other sequelae in categories, and then describe the injuries in the comments. Down at the bottom, tucked down there, is the vocational status. And so in that section, you want to indicate whether they were working full-time, part-time, self-employed, if they're a student, retired, and whether they are absent from their role as a result of the crash. So these two sections are page 1 of the form. So coming to the top of page 2, the this is really information about work and work suitability. So ICBC wants to know whether or not they have modified their duties if they're working at school and at home as their primary kind of vocational role. And if the patient isn't performing all their regular duties, they're really interested in what the impairments are that are affecting their work. So, if in my patient example, someone had a whiplash injury with minor concussion symptoms and vertigo, then they are likely complaining of myofascial pain as well as some other secondary symptoms. So perhaps they would complain of not being able to reach, bend, or lift repetitively. And so if my patient was an electrician, for example, that would be really relevant to their vocational status. Or if they were preparing quotes and couldn't tolerate the computer because of their persistent post-concussion syndrome, then it would be really relevant to indicate what their tolerance is for their work. This doesn't necessarily need to be like in the weeds, like an occupational therapy functional capacity evaluation. It just really broad strokes in talking to the patient. In the context of this patient example, I felt that their symptom burden exceeded what would be tolerable in a work setting. So I just indicated that I didn't feel a gradual return to work was appropriate. And I think when you see a patient for an initial consultation, as you all know, sometimes it's not really clear what the course of the patient's journey is going to be. And so it's perfectly appropriate to indicate that the return to work date is unknown. In the avocational status section, I like to indicate that patients are dependent on family for housekeeping support or outdoor maintenance or seasonal outdoor maintenance, whatever has really been the chief complaint from the patient in terms of how it's affecting their function. And then similarly, if I feel their symptom burden is too high, then I'll indicate they're not able to engage in that, and that I might even indicate that that's appropriate. Being a physiatrist, I think pacing is the cure for everything. And so I often indicate that it's reasonable for patients to pace themselves because I feel that performing your own ADLs and IADLs and incrementally taking on more independence is actually part of your rehab. So my lens here is kind of obviously stated, but whatever specialty language applies to you, you could put it there. This is an important section, this medical restrictions and limitations. And so, if someone had a vision loss, for example, and they're a driver, then their homonymous hemianopsia would be a contraindication to them returning to driving. And that's where you would, put this information for the recovery specialist. Similarly, I had a patient who had a vertebral artery dissection from an injury, and they were like medically contraindicated to returning to work as a cashier, loading things and exercising, and they couldn't engage in active rehab until their follow-up visit, demonstrated that things had resolved. And so that would be where you put this type of information, and that client would not be medically suitable to return to work. And being that clear is really helpful for the recovery specialist and your patient, then they don't get the runaround. So in my patient example, there are some modifiers to their injury. There's depression, there's vertigo. And in my experience and in the medical literature, those are negative risk factors for prolonged recovery. So I'm going to inform the recovery specialist, like expect a slow recovery here. And barriers to recovery that have been identified in the first 5 years of enhanced care is, and when individuals don't have a family physician or they speak English as a second language, then they may have difficulties accessing the care that they need or understanding the directions provided to them. The next section is the recommended care management plan. And I've just kind of thrown everything here in terms of a comprehensive management plan, but it's can be as comprehensive or as targeted and specific as you want. Um, the more specific you can get with your kind of prescription, so I would expect that an individual would improve kind of within 12 to 18 sessions of vestibular physiotherapy if they have persistent post-concussion syndrome. It can be quite helpful to try and provide some guardrails around therapy because if you don't, then patients can kind of be lost in their therapy for months, and it may be 6 months in between your visits with them, and maybe their status really hasn't changed because they've just been on autopilot. This prognosis and recovery timeline section is interesting, and I think will continue to evolve over the next several years. But I like to use this section to educate the recovery specialists and really advocate for what I think my patient needs. Like in this case, mental health supports are really important, and mental health supports are really difficult to access. And so if I feel that someone needs counseling and psychology, I'll put it here, for example. I also like to tuck in because I know that I need to start advocating early for my patients, and they likely won't see me until 9 months to a year after their injury. I like to tuck in that, if the patient's not back to work by 2 years, they need to be on the vocational rehabilitation pathway. And so if I see them at a year and they're not back to work, the likelihood is they're not going to be back to work at 2 years. And so I like to plant the seed there. Any additional comments you have would be helpful in this work, as well as in my MSP work. I'm also I might not appreciate the importance of validating what an occupational therapist might be recommending, but having done independent medical examinations for the last 5 years, as well as been a CNA assessor, I know that patients are often given the runaround around simple things like a computer overlay or vestibular versus vision therapy, or in the context of my inpatients, like a stair glide. And if you validate that some of the equipment recommendations are medically necessary in this additional comment section, I think you can just kind of save everybody the hassle of advocating back and forth for necessary equipment. That's all I have on the form. Any questions that we could take right now?
I don't see anything specific coming in right now, so I'll keep moving and I'll bring us into the billing information session. So thank you so much, Dr. Holtz. I think it's really helpful to see how this information is used and relayed in one context to help kind of draw parallels to other contexts. So I hope everyone found it as informative as I did. So moving through the billing information, I will move quickly because this information is also available in the ICBC Doctors of BC billing guide. But where do you find these reports? They're available on ICBC Health Services physician page and in the forms repository of pathways. Submission options are fax or mail, and I suppose perhaps carrier pigeon, but that information is also available on the actual report. So you don't have to worry about saving this information. It'll be there for you when you need it. Moving on. There are some billing rules just to be mindful of. So these reports were built and created for enhanced care. So a patient who had a motor vehicle accident before May 1st, 2021, it would not apply to, but it's for all of your patients whose accident occurred on May 1st, 2021 or later, and they're referred for initial consultation for those crash-related injuries. The specialized services reports do not require an invoice. The report itself captures all the information that we need to pay you for your service. So when we get it, well, we can pay it. And it's just important to make sure that it's complete so that it has the patient's ICBC claim number, an invoice number, if applicable for your own accounts receivable purposes, and your vendor number and payee information. So again, we can validate that we're sending the money to the right source for payment. The report fee of $275 does not include payment for that office consult. So again, you just follow your normal MSP processes for billing codes for that. It's just important to note too that ICBC doesn't pay for any missed or canceled appointments, so your normal office policies would apply in those cases. And we try not to prepay for reports because that can create a whole bunch of confusion. And so we just want to make sure that, again, you're aware of the May 1st, 2021 or later for the crashes for which this report would apply. And at this point in time, that would be probably many of the ICBC patients you'd see in your practice. So there are a few fees you may encounter through working with ICBC patients and working with ICBC that would require an invoice. So the physician conference fee, which is for written or verbal consult between yourself and ICBC or perhaps another treatment provider. Often occupational therapists may make use of this. So it supports that. It's payable on 15-minute increments up to 3 units daily. And again, more information is in the Doctors of BC ICBC fee guide. A few other fees requiring an invoice, obviously, clinical records. We really appreciate an itemized invoice that really outlines all the pieces of that fee so that we can just validate that the fee is reasonable. We do have a duty to check that fees are reasonable because we have a duty, fiscal duty to our ratepayers in administering benefits. So the best way to send us an invoice is to make sure that it's itemized and outlines your record review time, photocopying if it requires an uplift for being a complex record, and perhaps any administrative support time that you need to include there. Lastly, here I've included the fee codes for the medical legal letter or report. We may send you a letter requesting information to answer a specific question or questions. So that's when these fees would come into effect. And same thing, if you're not sure what fee to apply, if it's not clearly outlined in the request letter you receive, it's absolutely reasonable to reach out to ICBC and confirm the fee information before you do any of the work. All invoices do require the ICBC claim number, the patient name, the physician providing the service, and that payee vendor number, payee information. And they can be sent to the same places that reports go so that we can put them on the file and proceed with payment. So putting it all together in your practice, a few key steps to take away from this session to make working with ICBC easier are as follows. It would be best practice to identify an ICBC champion in your practice who can contact ICBC and confirm your vendor number. Check how payments are going to be made. So is that by check or EFT? Do you want to update that information? And get themselves familiarized with ICBC fees and those related uninsured services fees so that you're kind of prepared for when you see the ICBC patient in your office. Make sure that you locate the specialized services form and how you're going to access that in your practice or through your day. And then create and confirm an ICBC workflow with all members of your team. So how will ICBC patients be ID'd so that you know that that report may be completed? Review how other ICBC requests will come in, who's going to handle them, and how are you going to track them to completion? Because we know if you have to follow up with ICBC, we don't want things to get lost in the mix, and having a plan for that can really help. Also, Dr. Holtz helped create these few key steps, probably from her own learnings in her practice. So it's nice to learn from other people where we can. So thank you so much for contributing to that. Last, I'm just going to show you how you can find ICBC support and resources to get information when you need it. So it is a little not intuitive finding information if you go to icbc.com. You can use the search bar, but I always like to just give you the breadcrumbs to find the information when you need it. So physicians and other health partners are lumped in under business partners. Certainly not intuitive to yourselves that you would see yourselves that way. But once you click on that button, you can kind of see how we do have so many different partners that help our customers get going again after they've had a crash or made a claim. So right there in the middle is health services. If you click on that, that'll take you to our health services landing page. From here, the two key areas I want to draw your attention to are the physicians page and the contact us page. So the physicians page is going to give you all the information I've shared with you tonight and more, including those reports and some other information. And then contact us is your best resource when you have questions. So under contact us, there is the healthcare inquiry unit information. They're a phone line and email answering center, and they're excellent. So they can confirm the ICBC recovery specialist for you, check that the claim number's correct. So maybe your patient's kind of fumbling with paperwork and they're like, I think it's this. You can get that confirmed through our healthcare inquiry unit. They can answer basic billing and process and support questions. And then also found there is our claims vendor inquiry unit. So if you think you haven't been paid for something, you can let them know, share the invoice information, claim number, patient name, and they'll look on the file and figure out what happened to that payment that you were expecting that you maybe didn't receive, and other financial questions can be answered by that team. So with that, I'm going to take a pause and move us over into the Q&A session for the remainder of our evening, which is almost a full 15 minutes. So I look forward to supporting any questions that you have for us this evening. Thank you.
Thank you, Stephanie, for presenting today, and Dr. Holtz for walking us through the great detail of the specialist services report. So yeah, I do see a few questions in the Q&A session and also in the chat. So walking through our first question from Dr. Davidson, there are two parts to this question. The first one is, should the specialist services report be completed with every new ICBC patient, or do they wait for a request from ICBC? And the second part is it billable separate from the MSP consult fee?
Thank you, Namrata. So to answer this question, definitely when you're seeing a new patient for ICBC injuries, if their injuries are May 1st, 2021 or after, that is exactly who these reports are intended for. It's recommended to get consent to share it in every visit so that we get that information proactively that Dr. Holtz took us through. It can be really, really useful to get your insights to support funding the right things at the right time for that patient. And as I mentioned, definitely important to note that the fee for this is separate from the MSP visit fee codes that you would bill through MSP. So you have these two different ways to be funded for that consult if you're completing the report. The report itself has a fee attached to it, and then normal status quo billing for that consult visit.
Thank you, Stephanie. We have our next question from Dr. McNichol. And this question is, what is the best way to contact ICBC about the content of the specialist report, given that specialists do not always have the recovery specialist contact information?
Yeah, thank you for that question. I really want to highlight how the healthcare inquiry unit can be an essential resource in your practice. I strongly recommend bookmarking that page for your staff so that they can reach out to ICBC and check information as you may need it, whether it's checking on a process, checking on a claim number, checking who at ICBC is that recovery specialist if you need to send them a question or information directly, that they're a tremendous resource and are really well equipped to support you.
Thank you, Stephanie. I do see another question in the chat, and it is in regards to pediatric patients. And this question is for pediatric patients. Physicians assume that they are comparing functions to their pre-injury or age-typical ADLs or IADLs.
Yeah, I think that is a reasonable assumption. We understand that you're seeing this patient for the first time, and so probably part of your history taking is identifying what was their normal status pre-injury, probably relying on parents to convey that. I think that's reasonable, and making a relation to what you would expect for that same age for typical ADLs and IADLs, that would all be reasonable. And the way you would kind of normally convey that, making it as clear as possible, because our recovery specialists don't all have pediatric training. But yes, that does make sense, and I think it would be most useful.
Great, thank you. Our next question in the chat is, when would an A0071, 72, or 73, which is a medical legal letter, be requested from ICBC in the enhanced care system?
It's a great question. There could be a couple different points where we're looking to gather information that may need to be elaborated on. So we may have some information from a physician report or another source, or it may come to something a little bit more unique to the patient circumstance, and we may be looking for your guidance on. I can't think of a real concrete example off the top of my head that would be widely applicable, but I know, for example, after a few years pass in a claim, we start to look at when to offer additional types of benefits like vocational supports, or if we're really trying to understand if a customer has exhausted treatment options and has reached a functional plateau. So now, instead of looking for functional progress through treatment they may be undertaking, we're looking more through the lens of sustaining the progress made, preventing decline in function, and managing flare-ups. So there may be points in a recovery journey where everything in a report may not really be necessary, but we may have, one or two specific questions to help guide the administration of benefits and ensure that we're understanding where that person is in their recovery journey. Is there anything you want to add, Dr. Holtz?
Yeah, thanks. In our discussions between physicians and ICBC, it's come up that in these early years of the program that recovery specialists may not have been aware of the specialized services report form and may be requesting information from you in a letter form with specific questions. And they've been discouraged against doing that and instead encouraging the form. And so in response to those types of requests, I have my staff write back, which of the medical legal fees would you like me to bill for this inquiry? And then that generally prompts them to perhaps ask their manager or, escalate. And so we aren't expected to answer those questions especially if it's around prognosis and maximal medical recovery. And so if you are getting a letter that's asking you to provide an opinion on diagnosis, prognosis, functional impairments, and has the client met maximal medical recovery, I'd really strongly encourage you to direct that back to ICBC so they can provide some clarity.
Yeah, thank you. Also, if you had recently seen the patient for that initial consult and completed the specialized services report, having your staff confirm that the report itself didn't address the inquiry can save some work and some time. And so with a bit of experience, there may be a few different canned responses to ICBC your office may want to utilize, and that would be potentially quite reasonable, especially as we mature in our ability to ask the right question at the right time of the right person too. So we're still learning as well. Thank you.
Thank you, Stephanie, for giving more context, and Dr. Holtz for clarifying. So moving on to our next question in the Q&A. There is a question that in the off chance a patient presents with post-traumatic stress disorder or significant mental health symptoms to the emergency department, and they are seen by a psychiatrist, is the emergency psychiatrist eligible for the completion of the form and the reimbursement?
That's a great question. To the emergency department, we didn't design the reports with the intention that they'd be completed by emergency department physicians or physicians that support in the ED. On the family physician side, when a patient presents to the ED, we'd expect that the longitudinal care is being referred back to the family physician, and they'd be the most responsible physician for completing the report. That said, if you're making kind of detailed recommendations in the same context as if it were uh, a consult, I'm not sure. And I think that's one that I'm going to have to politely take away from our conversation this evening. But Dr. Holtz, jump in.
Thanks. I know that from our reporting recently at a meeting that physiatrists, orthopedic surgeon, and neurosurgeons are the ones completing these forms most frequently, but that we don't have, a spike in form completion that ICBC can't handle financially. And so I have to say that practically speaking, if a patient is presenting to emerge in crisis following a motor vehicle accident, and they are lucky enough to see a psychiatrist, please fill out the form and send ICBC the bill and whatever you can provide in terms of what the patient needs. If there's something that ICBC can do for them, it would really, really help. Having seen those patients downstream, then 6 to 9 months later. So this is my plug for yes, fill it out, see what happens. And Stephanie will rein us in if there's too many psychiatrists filling out the form.
Yeah, absolutely. I don't see that ever being a real problem that we would have. I just also want to be cognizant that me saying yes, complete the report doesn't add an undue burden into what you're already facing. So I think I can support that response. Absolutely. Thank you.
Great. Thank you. We have our next question, and thank you all for keep those questions coming. These are some of the great questions. Our next question is from Dr. McNichol. How can we get information back after completing the specialist report? Example, ICBC's decision?
That is an excellent question, and I'd like to thank you, Dr. McNichol, for bringing that forward. I can share that communication is a big priority for us to improve over the next kind of fiscal year and beyond. We don't actually have an exact way of doing this currently, but we are looking at better ways of informing care teams of benefits that are being funded and provided and utilized by patients or our customers. So I don't have an answer for you now. I think the patient themselves can hopefully provide some insight, but I know that having something a bit more concrete may be favorable. And I look forward to having a better answer in the future.
Awesome. Thank you, Stephanie. Our next question is from Dr. Krivoluk. I hope I pronounced it right. This question is, does ICBC want this form after every single follow-up with the patient, or only when the material change occurs that alters the plan?
I would say when there's a material change that alters the plan, but I would invite Dr. Holtz to weigh in with her own experience about how she kind of navigates that decision tree.
Thanks, Stephanie. In patients who I feel you know, have a family physician who they're seeing regularly, perhaps have been referred appropriately for a comprehensive medical assessment and are working their way back to work, then I fill it out once. And then, if I see them in follow up and things haven't materialized or I need to advocate, then I'll fill it out again. for patients who don't have a family physician or for some reason aren't accessing and obtaining the benefits that I feel they deserve, then I send ICBC a form every time and reiterate what I feel very strongly I need to advocate for. So I think, there is even though I think the form is fairly well compensated for the time it takes, there is an additional burden of having that time to complete it. So it's really up to how you want to fit it into your day if you have a busy day of follow-ups. I use it as a form of advocacy because of some of the communication challenges that I think we're still working out in being able to communicate with recovery specialists.
Thanks for that. I appreciate that context. It's certainly a great way of ensuring that ICBC is aware of what the recommendations are, whether that's equipment or interventions, or perhaps even another way to access uninsured services in your practice. I know, for example, injections can sometimes be recommended, but they do require a funding review on our side. So they are a great way of making sure that it's clear what you recommend for that patient, whether it's from yourself or from elsewhere in the benefits scheme.
Thank you,
Thanks.
Stephanie and Dr. Holes. Being mindful of the time, I think we are at time. So I know we do have a few questions in the Q&A section, and we are tracking all these. And we would definitely be reaching out to all the participants with the answers of these questions. And having said that, I would pass on to Stephanie for closing remarks.
I'd just like to thank all of the Doctors of BC staff that support putting these webinars together, and for yourselves for taking the time to join us this evening. I hope this information is helpful, and I hope you do bookmark where you can go for information as you need it in your practice. Please don't hesitate to reach out to our healthcare inquiry unit or have your team do that to ask and get answered those questions that you have in your practice, so that you can treat ICBC customers or your patients with confidence and help them in their recovery. Thank you so much for your time, and I look forward to making sure that any information we share afterwards answers those outstanding questions. Have a great evening.